Good afternoon. I'm Mark Nelson. I'm one of the co-chairs of the conference and I work at Imperial College in London. And it's my delight to welcome you to the first oral abstract presentations of the conference, where we'll be looking at diagnostics and investigations. So the first speaker is Halemichael Desalegn from Ethiopia, who's going to present on assessment of non-invasive markers of liver fibrosis in patients with chronic hepatitis C in Ethiopia.
Okay, thank you, Kolla, for giving me this chance to present my abstract on this virtual conference platform, and I feel honored. So this poster is on assessment of non-invasive markers of liver fibrosis in patients with hepatitis C virus in Ethiopia. So I have nothing to disclose. My outline looks like I'll go with the background. I'll try to discuss the methods that we have used, and then I'll discuss with the results, then discussion and conclusion and final recommendation based on the study. So background, we have seen that nearly 71 million people had global hepatitis C virus infection. There are some recent updates, but we have seen that around 10 to 15 million of these people actually live in sub-Saharan Africa. And actually 20 of the countries that have the global burden of the hepatitis C virus also live in the low and middle income countries. And despite this number, less than 2% are identified, diagnosed, and on treatment. So hepatitis C virus but we have seen that hepatitis C virus treatment has an SVR rate of more than 95%, and with an effective treatment of 2 to 3 weeks, yet patients are not identified and treated. And patients who are on DAA, even though they have SVR, they are likely to have to progress to decompensation and cancer. And there is a need of follow-up of their liver status. If you start them when they have early cirrhosis or cirrhosis, it's a progressive disease, so we need to have a follow-up. So we need non-invasive tests to identify the patients who have cirrhosis, even though they have an SVR. So it's a progressive disease, and cancer has been reported mainly also in those patients who have SVR. So the use of non-invasive tests for assessment of a liver fibrosis and cirrhosis would be very important in resource limited settings. With the liver biopsy it's not feasible. Transient elastography has also been shown that it's expensive and it's not usually affordable, and it's not available in many parts of African or sub-Saharan Africa and other low and middle income countries. And the other important thing also, we have, if we screen patients with hepatitis C virus, we also need to prioritize those patients who need early treatment, like patients who have cirrhosis, so that they will have early treatment, and also patients with cirrhosis who have been on treatment also needs follow-up even after completion of the treatment. So to prioritize patients to start treatment, and also for follow-up and for monitoring purposes, we need to have a non-invasive test that's not like a liver biopsy or a transient elastography. So we want to assess, actually, to validate the known non-invasive markers which are based on liver biopsy, like APRI and FIB4, whether they are actually feasible to be used. So we set up at our hospital, which is St. Paul Hospital, Millennium Medical College, which is one of the tertiary hospitals in Ethiopia. We use the FibroScan as a gold standard. We have seen previous meta-analyses. They recommend FibroScan for Hep C patients as a gold standard. So we use the different thresholds to diagnose no fibrosis and also cirrhosis. We use 11.7 to diagnose cirrhosis, and less than or equal to 7.9, no fibrosis. This is from studies in the African, Asian, and also other European countries. And we compare mainly the APRI and the FIB4 against this gold standard. Then we assess the sensitivity, specificity of the tests, different predictive values, and then we use the AUROC, which is the area under the reservoir operating curve, to the liver biopsy. The criteria used are mainly those who can't consent, adult patients. At this clinic, mainly see adult patients. So we see adult patients who are able to give consent, who have confirmed hepatitis C virus, and that are willing to be enrolled and participate. And we exclude patients like who had prior treatment with DA, patients who had diagnosed with HCC or comorbid illness and terminal illness had been excluded. So majority of them were women, and the median age was 50 years. And we have seen major genotype in our countries, genotype 4 and followed by genotype 1. And we have seen that the sensitivity of the APRI at a lower threshold, 0.5, was actually 75 with AUROC of 0.84. And you can see for cirrhosis, as at a lower threshold, has a sensitivity of around 75 and specificity of 95 with a ROC curve of 0.90. You can see the FIB4, also almost comparable, but it has a lower sensitivity and specificity from this study. You can see this graph showing the AUROC for A, as you see for fibrosis, significant fibrosis, and in B, we can see for cirrhosis. So the AUROC for APRI quite better than the FIB4 actually in these studies, especially for diagnosing of significant fibrosis. So this shows that APRI has a good diagnostic performance, but the cutoffs that had been used in different countries or recommendations like 2 was actually showing a lower. So we had cutoff 1 has a better sensitivity and specificity. So my conclusion is non-invasive test, especially APRI, has a good performance to detect cirrhosis at a lower threshold. So it can be used for early diagnosis and follow-up. So we recommend actually other for collaborative studies to see the APRI and to assess the different cutoff values. And I recommend, this study recommends a cutoff of 0.5 and 1 for severe fibrosis and cirrhosis respectively. So thank you for your time and attention, and this is my email address. I also would like to invite you for the next African Hepatitis Summit, which will be held in Ethiopia. And thank you so much.
Thank you. The next speaker is Zanab Ingabire from Rwanda, who's going to present on FibroScan findings in patients with chronic liver disease and the experience in Rwanda.
Thank you, Chair. Thank you, Code Organizing Committee, for this opportunity. My name is Zanab Ingabire. I'm a fourth-year internal medicine resident at University of Rwanda. My co-workers, Eric Rutaganda, Vincent Sarejambo, Benveni Muvunyi, and Dina Nyaming helped me preparing this work. I appreciate the input of Professor Dave Van Leuven, who, as a part of the Human Resources for Health, works with us on behalf of the Giselle School of Medicine at Dartmouth College in New Hampshire. I do not have any disclosures, nor do my co-workers. Timely diagnosis and particularly staging of liver disease is important. They help to decide either specific treatment like antivirals or preventive treatment like screening for cirrhosis-related complications is needed. Transient elastography is worldwide replacing biopsy for staging liver fibrosis. It is non-invasive with a good accuracy to detect significant fibrosis and cirrhosis. It translates liver elasticity into numeric scores ranging from 2.5 to 75 kilopascal, but there is no data about its use in Rwanda. We aimed at exploring the use of elastography in Rwanda, assess liver stiffness in patients with chronic liver disease, where the management where applicable, compare elastography results with APRI and FIB4 in chronic hepatitis B and C. Patients with chronic liver disease were recruited from CHK Internal Medicine Clinic from September 2019 to February 2020. 153 patients were selected for FibroScan after reviewing exclusion criteria like unable to consent, pregnant women, limitations or factors influencing stiffness like ascites. College of Medicine and Health Sciences Institutional Review Board approved the study. For every patient, fibroscan examination with a medium probe was done according to EFSMB guidelines. 151 patients had valid measures and were included in the final analysis. We used validated cutoff values. EPRI and FIB4 were calculated according to WHO recommended formulas. Detailed characteristics of our patients are shown in this table. We highlighted that our patients were in middle age, not obese. Hepatitis B and C occupied 95% of cause of liver disease. Fibrosis stages were classified according to Metaville scoring system. As importantly, nearly 20% of our patients had advanced fibrosis. It was urgent for them to screen for cirrhosis-related complications. EPRI and FIB4 performance were assessed based on transient elastography. In patients with cirrhosis, EPRI was able to detect 28%, missing 72% of patients with cirrhosis. And again, EPRI could detect 24% of patients with significant fibrosis, missing 76% of patients with significant fibrosis. FIB4 correctly identified 43% of patients with significant fibrosis. Both two scoring systems were not sensitive but specific. As conclusion, we were successful in obtaining good readings in nearly all patients, probably due to selection bias of study subjects. Transient elastography provides immediate results and performs better than EPRI and FIB4. Nevertheless, we had limitations. Elastography was not applicable for everyone. We presented the patients who had different causes of liver disease in our study. EPRI and FIB4 assessment were based on fibroscan measurement due to liver biopsy limitations in our setting. Thank you.
Thank you. The final speaker in this session comes from Burkina Faso. It's Nanolin Alice Guinjan. I hope that's pronounced right, but I'm going to have even more problems with the title, which is in French, but I will do my best. The title is Évaluation de la détection de hepatitis B antigen pour l'identification des charges virales élevées du virus de l'hépatite B exposant au risque de transmission mère-enfant malgré la vaccination à la naissance. And I hope at the end of this, I will have learned exactly what I have just introduced.
Good morning or afternoon. It's my pleasure to present to you the summary of our work on the performance of hepatitis B e-antigen test as an alternative to viral DNA to assess eligibility for treatment among pregnant women in the context of mother-to-child transmission of hepatitis B virus. Burkina Faso is located in an area of high prevalence of hepatitis B virus infection. Indeed, a study carried out at the national level has revealed a prevalence in the general population of 9.1% and 7.8% among women. In Burkina Faso, transmission is essentially maternal-fetal. Despite this fact, very few actions are undertaken at the national level to improve the care for these women, especially when they are infected by the hepatitis B virus. Despite the two strategies known worldwide, namely serovaccination of newborns in the first 24 hours of life and the treatment of highly replicating infected women, very few actions have been undertaken, and the application of these techniques at national level is largely insufficient. As regards the treatment of highly replicating mothers, the identification of this replication uses viral DNA as a main marker. However, this achievement has been identified as a barrier to the adequate treatment of women because it's very costly. In fact, this viral DNA is often carried out in daily practice by PCR. It is a technique that is expensive. It also requires sophisticated laboratories and highly qualified staff. An alternative to this examination would therefore be the use of hepatitis B e antigen, and the strategy would be to treat all hepatitis B antigen positive women. This test is much more feasible with rapid screening tests, but also with laboratory immunoassays. What is the particularity and what is the interest of this issue for Africa? There is a low number of studies in Africa, but also since 2015, WHO stressed the need for quality studies on this issue. Why contextualize the debate on this issue? The vast majority of data available to us comes either from Asia or from the European continent. However, there are peculiarities in the very natural history of infection in Africa, including an infection that occurs much earlier in Africa than in Europe, and the existence of an unknown percentage of pre-core mutation that is much more common in Africa than in Asia. This is how we set out to evaluate the performance, that is to say, specificity and sensitivity of the hepatitis B e antigen test to diagnose high levels of viral DNA, that is to say, highly replicating women's form during pregnancy in a program for the prevention of mother-to-child transmission in order to be able to offer this hepatitis B e antigen test as an alternative to DNA in public health strategies and among people living in resource-limited countries. What was our strategy? We used a cohort studied in a hospital setting in a monocentric study. It was a routine care cohort. In routine care, we dealt with women who were entirely dependent on themselves in order to identify the difficulties encountered in the follow-up of these women in real life. We then identified a subgroup of populations who were able to achieve both HBe antigen and viral DNA during pregnancy without treatment. Then we chose two thresholds, the threshold of 200,000 international units and the threshold of 1 million international units for viral DNA to detect highly replicating women. In total, 600 infected pregnant women were regularly followed up at the Yalgado Hospital in the center. The HB e antigen test was possible for 75% of them, and the test of the viral DNA alone in only 50% of cases, and both viral DNA and HB e antigen tests were possible for 44% of the cases. Some social demographic data on these women. They were relatively young women with a median age of 26 years. They were mainly educated and lived with a partner in more than 90% of cases, and were multiparous in 34.5% of cases. At the threshold of 200,000 international units, the sensitivity and specificity were 63.6% and 94.8% respectively. The best results were given by the threshold of 1 million with sensitivity and specificity of 64.5% and 93.7% respectively. The negative predictive value at the 1 million threshold was 93.7%, which is very interesting. And we can therefore conclude that these results position HBe antigen as a potential alternative to viral DNA in public health strategy and in countries with limited resources, in order to detect highly replicating women and thus prevent mother-to-child transmission in mother-to-child transmission prevention programs. However, there are still huge challenges, notably the implementation of all existing strategies and the use of high-quality studies to confirm the results presented here. Thank you for your attention.
So that's the end of the session. Thank you very much to all of the speakers who presented fantastically. We're now going to have a short break before we have our next oral abstract presentation session. Please go back to the timeline, and if you go into the next oral abstract presentation session, after this you will be able to meet with the presenters and then ask them all of the questions which I'm sure you have from the interesting sessions we're having.